Welcome, everyone, to this month's seminar on spirituality, theology, and health. We are excited today to have Rabbi Bruce Foreman talk to us about sleep, about insomnia, the spiritual sleep. So let me tell you a little bit about Rabbi Foreman. He received his PhD from Duke University in 1978, and he spent some time working in community mental health. He has done a lot of different things in his life. In particular, he was at the University of Missouri School of Medicine in positions in the Department of Psychiatry and Family Medicine. And that actually, University of Missouri is where I got my family medicine training as well. So we almost overlapped there. He was on the counseling psychology faculty at the University of Miami. And then he entered practice as a psychologist and got his rabbinical degree. And then he practices psychology in Florida at his own group there. He's authored over 60 scientific professional papers and book chapters and has written 8 books. Some of his books are, now listen carefully, Under the Chuppah, A Jewish Couple's Guide to Weddings and Meaningful Marriage, Smokescreen, A Jewish Approach to Stop Smoking, and then Rabbi Nachman's Tale, Stories for Personal Refinement, and most recently, Shall We Dance, An Enlightened Spiritual Approach to Becoming Jewish by Choice. And he has very graciously offered to share some of the PDFs of his books with anybody that emails him. So I'm thrilled to welcome and to introduce Rabbi Bruce Foreman. Go ahead, Bruce, take it away.
Okay, thanks. You know, I've been following Professor Koenig's work for quite a while, and I'm very grateful for the privilege of being here with you today to share my thoughts. With your permission, I'd like to dedicate today's learning to the memory of Colin Powell, who passed away yesterday at age 84. In Judaism, as in other religions,
Bruce, go ahead and unmute yourself.
Oh, there we go.
There you go.
How's
Sorry.
that? Oh, okay. And all right. So sleep is similar to the Sabbath in that not only does it provide for needed rest and rejuvenation and restoration, but we also take it for granted because it comes every day. So I've become fascinated with the subject, much like an infant who's just discovered her toes. I'm going to cover a number of topics about sleep and insomnia and best treatment practices. And you may already be familiar with some of the information, but some may be new as well. When you stop to think about it, it's easy to see that sleep is as important as eating and drinking and for maintaining proper body temperature. Beyond that, sleep helps in maintaining physical and mental health along with the sense of well-being we need for resilience. And as we'll see, not getting enough sleep is associated with higher risk for developing a number of health problems. Our interest in understanding sleep isn't new. We're curious since we spend about a third of our lives sleeping. Our interest in understanding the ancient perspective was that ordinary sleep is a gift from God. We find numerous references to sleep and dreaming throughout the Jewish Bible. You can see some of these here. In Judaism, which I talk about since I know a little bit about it, we derive a set of written laws contained in the Bible or Torah and they're referred to as halacha. And then we have the Talmud, which is a vast collection of biblical oral laws that are called Mishnah, along with discussions about them that are called Gemara. There's a story in the Talmud that describes a son who honored his father by his unwillingness to disturb his father's sleep, even at the loss of great financial benefit. And later on, he was bestowed with great riches as his reward. And that was an added bonus to the biblical injunction that honoring one's parents will be rewarded with a long life. In the New Testament, Jesus said, reciting the Shema is the most important of all commandments. And like many of his teachings, this was basic Judaism. While Jewish people have a zest for arguing and discussing all manner of ideas, throughout the world there's universal agreement that this is the most significant Jewish prayer. Even Jews who are not religious usually know the Shema. It is recited at bedtime, at each prayer service, and upon awakening, when we also say a blessing, thanking God for returning our soul and allowing us to live another day. This is the prayer that's also contained in a mezuzah that's affixed to doorways and homes and offices. In addition, the blessing of Hamapil is said just prior to going to sleep. This prayer is mainly about thanking God for the benefits of sleep and asking for a peaceful sleep uninterrupted by fright and improper thoughts. The code of Jewish law, which I said was halacha, is derived from biblical sources. In one law, it's recommended to spend some time before going to sleep to review the day, to find sins and missteps we might have made, so they can be corrected, to find ways of improving our character. A number of lessons about sleep have been culled from various writings. For instance, Maimonides, the noted 12th century scholar and physician and the author of the well-known work Mishnah Torah, shared best medical knowledge about sleep that was known at the time. And as you'll see shortly, some of his teachings are still true. There are teachings that are not in the code of law, but were developed by various communities and represent customs or local interpretations of biblical teachings. Each of these is termed a minhag, and the plural is minhagim. And Jews are taught that it's proper to adopt whatever local customs and practices are prevalent wherever they happen to find themselves following the diaspora or while traveling. This preceded the teaching that when in Rome, do as the Roman by several centuries. The Jewish mystical tradition speaks to the inner dimension of biblical teachings and practices to reveal the ideas that represent the essence. Here's a glimpse. Rabbi Joseph Gelberman, who was my teacher and Rebbe, would ask people, "Did you notice the miracle that happened this morning?" They would have puzzled looks on their faces and wondered what he meant. Then he'd say, "You woke up," and went on to explain how the soul ascends during sleep, and some souls did not return to their bodies. The teaching is that 1/60th of the soul remains, while the rest of the soul ascends to heaven during sleep. And Islam has a similar teaching. Even in ancient Greece, there was interest in understanding sleep. Aristotle proposed a novel theory. He believed that the digestion of certain foods created warm vapors that rise from the stomach and collect in the head, where they cool and condense. Then they flow down to the heart, which he believed to be the body's sensory center, which then causes sleep as it cools. It's very imaginative. Recently, where are we going? Oh, okay. Now let's take a look at what we know about sleep today from a somewhat more scientific perspective. Sleep is more than just lying in bed unconscious. In reality, it's quite complex. Sleep is required to regulate our homeostatic balance and follows a regular pattern. Sleep scientists have learned a great deal already, but there's still plenty more to learn. Recently, sleep researchers discovered that about half of the sleep promoting activity comes from the parafacial zone, or PZ, of the brainstem. This is a primordial part of the brain that regulates basic functions necessary for survival, such as breathing, blood pressure, heart rate, and body temperature. They found that a specific type of neuron in the PZ that produces the neurotransmitter gamma aminobutyric acid, otherwise known as GABA, is responsible for deep sleep. And we also know that the need for sleep changes over the lifetime. You may have noticed you can get by on a lot less sleep now than you did as a teenager. And more to the point, as we age, we need less non-REM sleep, and we'll be talking about that in a little while, as well as less REM sleep. And you can see that the need for sleep levels off in middle adulthood and then plateaus. In addition to the desire to understand sleep, we have been plagued by sleep difficulties for a long time. And here you can see a statement that was published in the British Medical Journal in 1894, not 1994, 1894. The National Sleep Foundation has estimated that as much as half of our population reports having at least some issues with sleep. In general, the few studies about sleep and religion parallel the trends and studies of the relationship between religious practices and religiosity and physical and mental health. So, for example, in a 2017 survey, it was found that stronger belief in divine control was associated with more hope, which was associated with better sleep quality. In other studies, Terence Hill and Christopher Ellison and their colleagues reported positive relationships between religious participation and comparatively better sleep. Another study by Kathleen Brewer-Smith and her colleagues, who included Professor Koenig, found that religiosity and spirituality was associated with better sleep in homeless women. Some other studies examined forgiveness and gratitude practice and found positive relationships with sleep quality. And of course, research in this area is a work in progress, and we'll see what happens over the next few years. Besides a high probability of seeing people with sleep trouble in our professional lives as physicians, nurses, psychotherapists, clergy, and chaplains, there are big financial costs associated with sleep problems. We now recognize that sleep occurs in stages that are divided into two categories. We have the REM sleep, which is rapid eye movement sleep, and we have non-REM sleep. Stage 1 sleep is a transition to sleep. It's dozing off and represents about 5% of total sleep time. Stage 2, we spend about 50% of total sleep time, which is light sleep. Stages 3 and 4 is the most restorative sleep. It's slow wave sleep because of the slow brain waves that it produces, and accounts for maybe 20 to 25% of total sleep time. And then REM, which is the rapid eye movement sleep, is the time when we dream. And that accounts for another 20 to 25% of total sleep time. We sleep in cycles that last about 90 minutes. Slow wave and REM sleep are more important for restoration than light sleep. But if we go several nights without getting enough sleep, we make up for the loss on subsequent nights by getting more slow waves and REM sleep, and this is called sleep debt. And here you can see the progressive sleep cycles. We go from light sleep to deep sleep, then getting lighter until REM sleep occurs, then progressive deepening. It's not uncommon to awaken slightly between sleep stages. Neuroscientists report that major shifts in the body position occur at least 14 times a night. So between the moving around and my sleep apnea, it's a wonder I'm still married. At a fundamental level, we can understand the two processes regulate sleep. These are body temperature and light. We like to think that our body temperature remains constant, but this isn't the case. Body temperature rises during the day and then drops in the evening prior to and during the time we're usually asleep. On average, our body temperature reaches its lowest point between 3 and 4 a.m. There are normally predictable variations in body temperature, although there are personal differences in range. As we reach a certain body temperature, too much environmental heat can reduce alertness. The timing of this, along with other bodily systems, is coordinated by the suprachiasmatic nuclei, a group of about 20,000 neurons located in the hypothalamus. We might think of these as being like a clock that tells all the rhythms when to switch on and off. Light and body temperature are closely related and affect how the sleep hormone melatonin is produced. Reduced light also stimulates the production of adenosine, a neuromodulator, which results in more sleepiness at higher levels. It's not unlike how light affects production of chlorophyll in leaves. Less light, as we see in the fall, inhibits the production of chlorophyll, and then that's what produces the spectacular colors we see in the trees. We have two competing drives: the drive to stay awake and the drive to sleep. People with insomnia are thought to have more of a drive to remain alert. As I mentioned earlier, this drive, like the rest of our biological clocks, is controlled by the suprachiasmatic nuclei. For many years, it was believed that adults had to have 8 hours sleep each night. Turned out not to be true. Now it's widely believed that the right amount of sleep is a range between 6 hours and 8 hours, averaging about 7 hours of sleep each night. Oddly enough, 6 to 8 hours of sleep was the amount of sleep that Maimonides, the 12th century Judaic scholar and physician, recommended. Even more of an eye-opener is that we can get by, at least for a while, on just 5.5 hours sleep, referred to as core sleep. The record for the longest documented time anyone stayed awake was established in 1964 by Randy Gardner, a 17-year-old who was awake for just over 264 hours, which is 11 days and 25 minutes, with the help of some researchers at Stanford. There's evidence that sleeping either too little or too much on a regular basis can reduce life expectancy. When deprived of sleep over the short run, this may not be true. After all, Randy Gardner is still alive and well. You can see here on the graph that too little or too much sleep is associated with mortality. And surprisingly, getting too much sleep appears to be worse than not getting enough. Some interesting findings show that overproduction of adenosine has been associated with chronic inflammation and organ damage, which may provide an explanation of why excessive sleep increases mortality risk. Poor quality sleep can result in undesired effects, such as motor vehicle accidents. There have been some studies that found when deprived of sleep, people adapt to their levels of sleepiness and are unaware of how much cognitive performance has declined as a result of the poor sleep. And this is thought to be a factor in accident proneness. And here we can see the relationship between insufficient sleep and number of motor vehicle accidents. Insomnia is implicated significantly more than obstructive sleep apnea, although both disorders are risk factors for getting into auto accidents. As many as 50% of all auto accident fatalities have been attributed to sleep deprivation, circadian rhythm disruption, or both. Problems with sleep are very common. Approximately half of US adults report having some sleep difficulty, and the incidence increases with age. Only complaints of pain are more prevalent. Aside from auto accidents, there are other consequences of poor sleep. These include mood disturbance and cognitive impairment that may interfere with learning. We can draw a number of conclusions about sleep deprivation. They're common but underdiagnosed, The consequences can be serious, but correcting poor sleep is possible. People usually want to know, do I have a disorder? How serious is it, and can it be treated? So we start with defining sleep disorders. The American Academy of Sleep Medicine has cataloged 83 variants of sleep disorders, along with diagnostic criteria. These are grouped into 7 categories. Insomnia is the most prevalent diagnosis and may occur alone or can be comorbid with other disorders. There's a high frequency of both comorbid medical and psychiatric disorders associated with disrupted sleep. It's about 60%. Most sleep disorders are treated with behavioral and medical interventions, along with dietary supplements, such as magnesium and vitamin B12 for restless leg syndrome. To make a differential diagnosis, we ask a number of questions. Do you experience or does your bed partner report leg or arm jerking while asleep? That would be periodic limb movement disorder. Do you have loud snoring, gasping, choking, or do you stop breathing when asleep? That's obstructive sleep apnea. Many times it has to be confirmed by a bed partner who reports how angry or frightened they become. Do you fall asleep suddenly during the day? That's narcolepsy. Do you have uncomfortable feelings in your legs that go away with moving them? That would be restless leg syndrome. And finally, do you feel fatigued during the day and are unable to function adequately at work or school? That's insomnia. We have a formal definition of insomnia that comes from the American Psychiatric Association's Diagnostic and Statistical Manual. And here are the criteria. And the ICD-10, that's the International Classification of Diseases, has a pretty similar definition, but it doesn't account for subjective discomfort or effects the way the DSM does in making a diagnosis. If someone's sleep has only those qualities we see here, we may never know about it because they don't consider it a problem. So it makes sense to include a subjective element. The International Classification of Sleep Disorders is a bit more detailed. Subjective perspective and self-reported issues are also considered within these criteria. And you see the list continues, so you can see it's quite comprehensive. Naturally, making a diagnosis of sleep disorder is complex, but to arrive at a provisional diagnosis of insomnia, we look at the total amount of sleep each night and query about sleep onset and maintenance, as well as negative effects during the day. I want to call your attention to the question about sleep maintenance. Time awake after sleep onset, or we use the acronym WASO, wake after sleep onset, getting up in the middle of the night and having difficulty falling back to sleep, isn't addressed in the diagnostic criteria, but sleep researchers regard this as a critical variable for understanding quality of sleep. Without considering WASO, we may get an inaccurate picture of sleep continuity and time spent getting enough restorative slow wave or REM sleep. We no longer consider etiology when making the diagnosis and do not distinguish between primary and secondary insomnia as used to be the case. There is evidence that even when an underlying medical condition is treated, the insomnia persists. What happens physically during insomnia? Well, we see more arousal of the wakefulness system and an increase in activity in several areas of the brain. We're not equally susceptible to developing insomnia, and there are a number of factors that increase risk. Perhaps one of the most fascinating is ACEs, that's adverse childhood experiences that occur during the first few years of life, like physical or sexual abuse, family conflict, substance abuse, poverty, and parental divorce, set up the child for a lifetime of medical and adjustment problems, including sleep difficulties. However, Brian McPhail at Purdue University recently found that adult religious involvement buffered the effects of childhood abuse on chronic sleep problems. Another recent study found that transgender or gender non-binary people are at higher risk for developing insomnia. Since these are single studies, we have to wait for more data to accrue before coming to a conclusion about the mechanisms that may explain this, but is likely to get more attention in the sleep science community. A key takeaway here is that while there may be risk factors, insomnia is typically independent of other diagnoses or conditions. And this is significant because it means that insomnia may be a comorbidity that can be treated independently of treatment for anything else, because insomnia is a diagnosable disorder. When insomnia is treated, we often see improvement in other disorders, even when those are left untreated. And this is part of what encouraged me to learn more about treating insomnia. There are numerous consequences of impaired sleep. We also find increased sensitivity to pain and decreased antibody production. A number of studies have shown that if you just repair sleep, many other physical maladies improve significantly. For instance, getting just 4 hours of sleep for 3 successive nights reduces glucose tolerance and insulin sensitivity sufficiently to look like a pre-diabetic state. Sleep deprivation also increases cardiac sympathetic activity that can lead to increased blood pressure and heart rate. 4 nights of sleep deprivation will also decrease the evening leptin levels. This is the hormone that tells the brain when you've eaten enough, while also increasing concentrations of ghrelin, the hormone that stimulates appetite and decreases the body's ability to burn fat. What then happens is overeating or evening snacking, which leads to obesity. And as we've seen, insomnia can produce or exacerbate a number of medical conditions. And here's some of them. Insomnia has serious implications for emotional health and increases risk for mood disorders, substance abuse, and even suicide. There are a number of common causes for insomnia. For instance, caffeine is a central nervous system stimulant with a half-life of approximately 5 hours. This means that food or beverages that contain caffeine should never be consumed within 5 hours prior to bedtime by anyone with insomnia. And patients should be encouraged to limit or eliminate all daily caffeine take, since individuals with insomnia tend to be particularly insensitive to caffeine, and its duration of action increases as the dose increases. Stimulants are often overlooked as a source of sleep interference and as a factor in anxiety and interpersonal conflict. Some years ago, I saw a patient who was nearly fired from his job as a paramedic because he got into conflicts with all kinds of people several times a day. And when we reviewed his caffeine intake, we discovered he consumed somewhere in the order of 800 to 1,000 milligrams of caffeine a day. That's the equivalent of about 10 cups of coffee. And that's a lot. We got him on a schedule of gradually tapering his intake, and within 6 weeks, he was getting along much better at work and at home, and he got to keep his job, and he got to stay married. Alcohol is a central nervous system depressant that may make falling asleep easier when consumed during the evening, but it may also depress respiration, precipitate snoring and sleep apnea, and potentiate sedating medications, suppress REM sleep, and produce awakening with difficulty returning to sleep. And of course, alcohol can be habit forming and require increasing amounts to produce sleepiness. People with insomnia should be discouraged from drinking more than a glass or two of wine with dinner. And as we've noted, insomnia is extremely common, and when left untreated, it can result in accidents and worsen both physical and mental health. But the good news is it's highly treatable. Since insomnia is not something new, we've had to contend with sleep deprivation for centuries and devised a lot of remedies. Many of them worked well, but had various unintended consequences, like overdoses or making the problem worse. Counting sheep was once thought to be useful, but this actually stimulates the brain. Today, a variety of medications, including anxiolytics, hypnotics, and antidepressants, are often prescribed. Trazodone, which is an old-line tricyclic antidepressant, is currently the most widely prescribed sleep medication, even though it's an off-label use, which means it wasn't approved as a sleep medication, but it's used anyway. Many primary care physicians have also found that trazodone is useful for pain management. Because insomnia is such a significant health risk, medication is recommended for short-term occasional use for acute insomnia. In fact, Dr. Michael Perlis at the University of Pennsylvania School of Medicine, one of the people I trained with, argues that it may be helpful to think of insomnia as being like an infection, and medication for sleep can be thought of more like taking an antibiotic. And here we see some important limitations about sleep medications, suggesting we should be cautious when we use them. All right, what about non-prescription sleeping aids? They may be useful for short-term use, but they're not without their side effects and unintended consequences, and they certainly will not eliminate chronic insomnia. Many people use melatonin because it's natural, but it's not a hypnotic, it's not a sleep medication, which is something that facilitates sleep onset and sleep maintenance. Melatonin is classified as a chronobiotic that's involved in the perception of light and dark and helps you know what time of day it is. One recent study found that melatonin decreased sleep onset by only about 7 minutes. Melatonin can be used to treat circadian rhythm disorders. CBD and CBN, cannabinol, we like to just use the acronyms to avoid confusion, are useful for managing pain and anxiety, so may be helpful when anxiety causes sleeplessness. Now, a recent study that I just came across a week or so ago reported on a study that was done in Australia that found that a combination of CBD, CBN, and THC were effective in improving sleep. I don't know if people woke up craving Oreo cookies, but it's interesting that these studies are being done. There have been recent studies providing some evidence for novel approaches to enhancing sleep. For instance, last year, a study was published in the Journal of Experimental Neurobiology that reported that exposure to smells derived from pine tree essence was effective for improving sleep because it increased relaxation and improved immune system functioning. Another study looked at reducing exposure to blue light for the 90 minutes prior to bedtime. Their positive results suggested this might be included as part of improving sleep hygiene. This is something I routinely recommend. And still another study found that earplugs and blindfolds improve the sleep of ICU patients. Then we have brain tapping. You may have heard of this. One approach uses acupressure points that are repeatedly tapped, and another emphasizes rhythmic drumming on the thighs accompanied by progressively slowed breathing. There's a tiny bit of research to support brain tapping as helpful with anxiety, but mostly there are anecdotal reports on help with insomnia. Then another study examined the effects of white noise and ocean sounds and found that sleep was enhanced. Being at the beach has a number of benefits to enhance relaxation and promote sleep. The sound of the water, the negative ions produced by waves, sunlight, and heat-induced sweating, which allows toxins to be released. I have a second home at the beach, and here's a picture of sunrise from my balcony, which is about 200 feet from the ocean. And when we're there, my wife and I sleep like we're comatose. And we're usually working, not vacationing. But it's not terribly realistic to send people to the forest or the beach on a regular basis to improve sleep, although you can keep it as an option. And maybe you're wondering, are there other ways to treat insomnia besides pharmaceuticals and these novel remedies? And the answer is yes, there is. We have cognitive behavioral therapy for insomnia, known as CBTI. Many people have heard of CBT, cognitive behavior therapy, which has become the gold standard for treating mood disorders. But CBT for insomnia is substantially different because it focuses just on sleep behavior and related dysfunctional thoughts. It is both evidence-based and presents no real hazards. Over the years, a substantial body of empirical research has accrued supporting the efficacy and effectiveness of CBT for insomnia, including a 2021 meta-analysis of behavioral and psychological treatment methods. Also, a recent economic evaluation published in Sleep Medicine Reviews found that CBT for insomnia can be more cost-effective than either medication or no treatment. How expensive is it to have no treatment? Well, it isn't, but the results can be expensive. What's involved in this approach? Well, there are several components of CBT for insomnia, and these involve education about sleep, including information on sleep stages and research findings on amount of sleep needed to function adequately in life, like I told you about earlier. Sleep hygiene considerations like room darkness and temperature create an optimal environment to reduce wakefulness and increase sleepiness. Being on a cell phone or sitting in front of a computer stimulates wakefulness because the screens emit blue light, which is activating. There's an app for computers that filters blue lights. If you want it, it's free. Just search f.lux, L-U-X. For iPhones, you can use the night shift setting. Or you can just get some blue light filtering glasses from Amazon for about $10. Some recent research suggests that blue light filtering not only improves sleep quantity and quality, but also improves outcomes for CBT for insomnia. Another element is stimulus control to maximize the association between lying in bed and going to sleep. If someone spends time in bed watching TV or on a cell phone or worrying, the brain gets confused, and we have to retrain the brain to understand that being in bed means go to sleep. We also use sleep restriction by changing time allotted for sleep, time to bed, and time to get out of bed. This promotes sleep consolidation, so there's a proper balance of REM and slow wave sleep to achieve restfulness. Several studies have shown that sleep efficiency, which is an index of time asleep divided by time in bed, that's below 80% is associated with increased mortality risk in elderly. Sleep compression to reset the internal sleep-wake clock and improve sleep efficiency might also be included. Sleep compression involves going to bed later or getting up earlier, or both. And as with other forms of CBT, we use strategies to make changes to unhelpful beliefs or self-talk. Not only does the self-talk include distorted beliefs about sleep itself, but the sleep talk may involve an overly analytic assessment of threat that can disrupt the hypothalamus pituitary adrenal or HPA axis. The result can be fragmented sleep or reduced time of sleep, which can then lead to dysregulation of cortisol production and compromise the immune system by producing neuroinflammation. We identify and substitute negative sleep thoughts with positive ones, or at least ones that are neutral. For instance, we might dispute the belief that unless I get 8 hours sleep, I won't be able to function at my job. This will be awful and I'll be fired. It's important that they're written, especially the positive sleep thoughts, since then we get practice with the more effective thoughts. Studies on CBT show that writing aids in getting good results more quickly. And we address anxiety as well. Roughly 60% of sleep onset difficulties involve anxiety. Interestingly, We know that sleep, especially more time spent in non-REM sleep and the slow wave sleep, reduces anxiety. And it appears that slow wave sleep increases activity in the brain's prefrontal mechanism that regulates emotions and lowers emotional and physiological reactivity. And then we consider worry. We may use paradoxical intention or prescribe use of a worry chair or a worry corner. We might suggest using worry dolls or writing each concern on a slip of paper and placing them under the pillow. And then in the morning, when you wake up, they're gone. We also provide relaxation training. Methods like progressive deep muscle relaxation, meditation, self-hypnosis, or deep breathing. In addition, we might recommend some of the things we learn from neuroscientists, including practicing gratitude to improve mood, setting goals to increase dopamine production, and getting physical exercise to increase brain-derived neurotrophic factor that makes our brain stronger and more resilient. To get a picture of sleep patterns, we use sleep diaries that include a number of elements such as recording time to bed, average sleep duration, time allotted for sleep, number of sleep onset and sleep maintenance insomnia nights of an hour or more, and number of awakenings. The most important is awakening time for regulation of circadian rhythm. The sleep diary is useful for evaluating progress. If you ask me, what's the one thing that will benefit sleep, is getting up at the same time every day, including weekends. CBT for insomnia has a number of qualities that make it easy to recommend. The benefits are long-lasting. Treatment is relatively brief, and there are no interactions with medications, and there's no risk of abuse or lethality. While CBT for insomnia has many advantages, there are some negatives as well, although they're minor. Probably the biggest obstacle is knowledge of CBT for insomnia and finding suitably trained therapists. CBT for insomnia is the recommended treatment of choice for chronic insomnia. Much like CBT has become the gold standard for treatment of mood problems, CBT for insomnia is widely recognized as the go-to approach for chronic insomnia. But there are limitations. A recent study found that many people who could benefit from CBT for insomnia just wanted a simple way, like taking a pill. CBT for insomnia with or without medication provides superior and more enduring results than medication alone. There's evidence that adding a sleep-focused component to any kind of talk therapy improves outcomes. Also, a 2017 study found that sleep aids in unlearning, which is an important component of psychotherapy. We sometimes see patients who are experiencing sleep deprivation or insomnia having difficulty benefiting from therapy, which tells us we should treat the sleep problem first. I'd like to finish by saying that we've seen that insomnia is very common. Without treatment, there can be serious consequences to both physical and mental health. Treatment with medication can be indicated when insomnia is acute and the need for symptom relief is immediate, such as when caused by a situational stress, illness, or jet lag. A short course of sleep medication can also prevent chronic insomnia by blocking poor sleep habits from developing. CBT for insomnia is highly effective and it's recommended as the first-line treatment instead of medication because it's safe, free of side effects, and provides long-lasting relief. It's well suited for treating chronic insomnia, as well as those times when medication's contraindicated, like for children, and for elderly when there's a potential for drug interactions or effects on pre-existing medical conditions like cardiovascular disease, substance abuse, and history of parasomnias. like periodic limb movements. Hopefully, my presentation hasn't contributed to your sleepiness, but has been informative, increased your awareness of insomnia as a significant health problem, and I hope that sleep problems can be effectively treated. Here are some resources that you can consult to find some clinicians who you can refer to if you know people who have chronic insomnia. And now we can open things to some questions and discussion.
Terrific. Thank you, Bruce. What a great and comprehensive discussion of sleep. I'm going to now open the floor. Anyone who has a question for Rabbi Bruce, go ahead and ask your question. Just unmute yourself and ask.
Yes, we covered everything.
Hi, my name's Yvonne. I work with the U.S. Air Force over in RAF Mildenhall, and I'm what's called a spiritual program coordinator. Thank you for your presentation. A question that I have: when you were showing data regarding positive correlation between religious practices and sleep, is the correlation primarily religious practices, i.e. Christianity, Jewish, Judaism, or does it extend to spiritual practices as well?
As I recall the studies, there wasn't much, but I think the measures were religiosity. And of course, spiritual practices can fall into that category.
It's interesting. I'm actually doing a presentation for our, I work with the special operations community, doing a presentation next month around sleep and spiritual practices and the correlation between sleep. So it was interesting to hear some of the studies. So I appreciate you sharing that. Thank you.
My pleasure.
I have a question about, I heard that like maybe during the Middle Ages, sleep was different, that they went to bed earlier, kind of woke up for a little while through the night, and then kind of went to bed again. And I guess I'm wondering, is there such a thing as like a sleep culture, or, like is sleep sort of the same throughout the ages and across, time and space?
Yeah, that's a good question. I'm not really aware of anything that speaks to that. Sleep is determined biologically, and while we've evolved somewhat biologically over the centuries, I think the need for sleep probably has remained unchanged, because we have different changes in our own personal sleep patterns seasonally. It's when I lived up north in the dead of winter, when it was 10 degrees below zero outside, I slept really well. And we know that cool temperatures is related to stimulating sleepiness. So I'm not sure. It's definitely an interesting question. I don't know how we'd find out what the sleep practices were in the Middle Ages, but I can't imagine it being much different today than it was then.
Anybody else?
I do have a question. My name is Maria. I'm with Fully Alive Health in Dallas, Texas, and I wanted to ask if you are aware if there is a CBT self-study program that is available, because I usually find there's a very limited number of trained therapists as it is. But if there was a program that could be translated. I almost see Latinos who are Spanish dominant that could, we could adapt it for incorporating spirituality approaches, but something that going through the program, then those peers could help other peers. So I just wanted to throw that out there because we work with Latino populations here in
Uh-huh.
Texas.
There's an app that is a self-directed CBT for insomnia program. I don't know if anybody's done any work to compare how well it works vis-a-vis a live therapist, but yeah, there's an app, and it, you just download it on your phone.
Thank you.
There are a couple of statements in the chat that I'll read to you. One of the viewers here says that I suffer from insomnia, and this was very good for me to have. The materials you presented were very good. My insomnia is severe, where I only get 2 to 4 hours of sleep a night. So thank you for this study that you've shared.
If I can comment on that, that's a very common observation that we see in clinical practice, that people say, "Oh, I didn't sleep at all," and the reality is that we're not such great observers of our own sleep process. 50% of the night is spent in light sleep. And often what happens during light sleep is we may temporarily awaken and fall back to sleep, but it seems like we're awake the whole time when we're really not. Polysomnography studies have demonstrated that when people say that they weren't asleep, they actually were. So 2 to 4 hours of sleep would create very significant kinds of health consequences. So maybe you're getting less sleep, but it's not that small of an amount, 2 to 4 hours. Really, there's light sleep going on.
Bruce, I've got a question. What do you think of these over-the-counter sleep aids like GABA? You can get these pills, to help you sleep. They say that, these GABA pills they're actually mostly made up of melatonin, but any thoughts on those over-the-counter sleeping aids?
Yeah, sometimes, the aids that contain melatonin aren't harmful because our the pineal gland produces melatonin, but the studies that were done recently suggest that taking melatonin and falling asleep is almost like a self-fulfilling prophecy, that I took the melatonin and I fell asleep and so it works. But it only increases, it only decreases sleep latency by a few minutes. On the average, it's less than 10 minutes. The sleep aids that contain melatonin are harmless, but the sleep aids that contain other things can create problems, because what they'll do is they will interfere with the balance of deep sleep and REM sleep, so that when that's changed, people wake up the next day and they feel they've had inadequate sleep, and then the next night they sleep it again, take it again, and then they still have a problem sleeping, and in time they're chronically sleep deprived. So we see this with prescription and non-prescription sleep aids, that they can have that effect. And the best advice I can give to anybody is, you don't need to worry about it. Sleep is self-regulating. If you miss out on some sleep tonight and don't get enough restful restorative sleep, tonight or the next night, you'll get it. Your body will restore itself, so you don't need to worry.
That's brilliant. Brilliant.
Yeah, I think that's the way God created us.
Amen. Any other questions that people have? We've got a sleep expert here. Take advantage if you can. If you have any questions about sleep or what you can do to sleep better, this is the time to ask.
Or send me an email.
Hi, this is Yvonne again with the Air Force. So one question that I've been trying to find some research or guidance on, many of our members find that they have difficulty sleeping because they're on call. So whether they're an operator and therefore they can never fully sleep because they're waiting for that phone to ring, or our rescuers who, because they're on call, or some of our leadership who are on call, but I have not been able to find strategies for helping individuals to deal with the ability to sleep when your job is on call, which is different than shift work.
Exactly. We've seen a number of first responders have sleep problems, and the sleep problems have then become chronic illnesses, and there isn't much you can do. It's it's a calculated risk. It's an occupational hazard to do that kind of work. I had a guy who was a paramedic or an EMT a couple of years ago, and he had very significant emotional issues going on, and because he would do 24 on, 48 off, and his sleep was really very disturbed, and so we had to get him changed over to a different work assignment that was 7 to 3. 5 days a week, and when he did that, his sleep improved, and his emotional issues took care of themselves. And so then we had to write a justification that that should be permanent, and he got to stay there, and I don't see him anymore because he's all fixed.
Wow.
Thank you for that.
Yeah, you've already said this, Bruce, but the sleep environment is very, very important in terms of it being quiet, it being cool. If you have chronic pain, try to take some Tylenol or something before you go to bed, so that doesn't disrupt it. If you have a bed partner that snores, that's an issue, and many people have sleep in separate bedrooms for that reason. But that environment is so important. Any other thoughts about the environment, Bruce?
Yeah, the sleep hygiene is critical. Mostly, it's being free from noise and free from distractions. It's making sure the room is cool enough. I usually recommend try to turn the temperature down an hour or two before bedtime, and turn the lights down because a little bit of darkness, of soft lights, helps to stimulate the production of melatonin and adenosine. The cool temperature kind of gets you sleepy. I recommend that people don't do any physical exercise an hour or two before bedtime. Don't vacuum the house and then hope you can fall asleep. You might be able to, but what exercise does is it raises your internal temperature, and then it makes it harder to fall asleep. So it's light and temperature are important, but also being free from from pain, distractions. If you got a trombone player living next door, you might need to either move or get some noise canceling earplugs. And then, of course, there's the anxiety. Roughly 60% of the people who have difficulty falling asleep have anxiety, so need to do some relaxation. So dealing with anxiety and dealing with worry are the things that often interfere with falling asleep. It's when we have the difficulties with sleep maintenance, and people have fractionated sleep, that they fall asleep and then they wake up and then they can't fall asleep, and we have some things that we recommend. But if you get up in the middle of the night, to go to the bathroom or whatever, and you can't fall back to sleep within 20 minutes, get out of bed and go someplace else, because otherwise your brain thinks it's okay for you to lie in bed awake or lie in bed awake worrying that you can't fall back to sleep.
How about reading the Torah? Might that help, like reading numbers or something of that nature?
Yeah, you can do that as long as you don't do it in bed.
Okay, Bruce. Listen,
All right.
We're at the end here, and I can't express my appreciation more for your taking the time to talk to us today. So thank you.
It's my pleasure indeed, and I feel it's quite an honor to be allowed to do this. So thank you.
Wonderful, and thank all of you too for joining us today. And God bless and stay safe.
All right. See you next month.
Okay. Bye.
Bye.